Welcome, everyone, and thank you for joining us for this social media event focused on pulmonary arterial hypertension, which we'll refer to as PAH. PAH remains a challenging condition. We need to recognize it early and refer quickly to an expert center, and that can be life-changing for our patients. I'm Dr. Jean Elwing from the University of Cincinnati, and I'm joined by two amazing young physicians, and I'd like you to introduce yourselves, Breanne and Sid. And it's my pleasure to spend some time with you today. Breanne?
Hi, everyone. My name is Breanne McCarthy. I'm a current third-year pulmonary and critical care fellow at the University of Pennsylvania and excited to be here today.
Welcome. Sid?
And hey, everyone, I'm Sid Narayanan. I'm a recent grad as of a week ago from the University of Cincinnati Pulmonary and Critical Care Division. And I'm very happy to be here. Thank you.
Yeah, great. And I think we're going to have a good discussion about pulmonary hypertension and your experiences as fellows and learners in this ever-changing field. So we're going to walk through some questions and some scenarios and talk about your perspective and experiences. So I'm going to start with Sid. And we're going to start with clinical classification. How do you use the clinical classification we're using currently in your practice and what you've learned from fellowship? And how is it important to determine how to manage patients?
Yeah. So I feel like when I'm first assessing a patient and there's an increased concern for pulmonary hypertension or pulmonary arterial hypertension, I think I use the clinical classification, the groups that we have, groups 1 through 5, to kind of give me the foundation for how I will obtain history from the patient. So I usually start from the top in group 1 and try to ascertain if there's any family history or any connective tissue disorder or any other risk factors associated like cirrhosis or HIV. And then kind of going down the line, I go through heart disease stuff where I usually have the information that's already been obtained either by the primary team or by physicians in the past, and then go through pulmonary disease, any history of clotting disorders, and then kind of wrap up with a sort of a miscellaneous group of disorders that falls under group 5. I feel like using that kind of approach makes sure that I don't miss anything, and I make sure that I have a very systematic way of ensuring I'm checking for every risk factor. But also starting with group 1, I think is very important too, because if I'm able to find out if they have a certain risk factor that puts them at risk of putting them into true pulmonary arterial hypertension, then that gives them the best chance of being a candidate for many treatment options that we have readily available now.
No, that's really good. And I think the only way you can do that if you have the knowledge and the framework in your mind to put patients in those categories. So I'm going to take a step back and ask Breanne. So Sid encountered a patient, it sounds like he knows has pulmonary hypertension, probably has already been diagnosed. But before that step, what makes you suspicious? And how do you really use the tools you have to differentiate from common cardiopulmonary complaints like wheezing and asthma and things of that nature versus pulmonary arterial hypertension or pulmonary hypertension in general?
That's a great question. So I think PH should be considered in any patient who has unexplained dyspnea on exertion. That's the number one symptom that can clue you into a possible diagnosis of PH, as well as any unexplained volume overload on exam, and especially if those things are associated with, exertional syncope or pre-syncope or dizziness. In terms of differentiating pulmonary hypertension from the other more common cardiopulmonary disorders, I think that a detailed patient history, like Sid already mentioned, is really critical. So asking those family and personal history questions, asking about lung and cardiac disease, connective tissue disease, do they have a history of VTE? And then just overall, I think the most important point is to consider PH whenever you have that patient with unexplained dyspnea. We know there's a delay in diagnosis for patients between when they first are reporting their symptoms and when a diagnosis of PH is suspected. So I've really tried to maintain a high degree of suspicion in my patients to recognize when there's a disconnect in their symptoms and their known diseases. So is that dyspnea out of proportion to what I would otherwise expect from their known lung and heart disease?
Very good. Very good. And I think that kind of ties both things together. So we get to our diagnosis of pulmonary hypertension through our baseline knowledge of this condition and the various causes. So, how do we get from where we've been assessing patients and working them up to sending them to a center to undergo the next steps, the next part of the evaluation? Sid, what would trigger you to make that call, to make that referral?
Yeah, so initially, if they have signs and symptoms up front that seem disproportionate to the rest of their past medical history, that could be uh, as easy of a trigger to send someone to refer. I feel like a lot of the times we receive patients and we assess patients after there's always already been an initial workup. So whether there's CT evidence of some kind of interstitial lung disease along with elevated markers such as a BNP, or if there's evidence of right heart strain either on EKG or if they've had a echocardiogram that's shown evidence of potentially RV dysfunction or RV overload, things like that. I feel like that's when we typically get patients seen in our clinic
Mhm.
first. And then only after that would we consider sending them for right heart catheterization because that's usually not done by the time we see them.
Mhm. So all of the high risk features would sort of direct you towards that referral. Now, now that you're done with your fellowship, does that change your approach? Are you planning to use what you've learned, work up patients, maybe even get the right heart cath before referring, or do you think you'll refer early before the right heart cath?
I I think it depends on how well the patient is doing and how how abnormal the initial test studies I see are. I feel like something that's easily done in any institution is something as simple as getting labs or getting a echocardiogram, because I don't want the patient to have to wait extended amount of time for those initial tests to get done. But I think at that point, especially if my suspicions are high enough and I'm concerned about them, I would rather send sooner than later just to not allow delays in the treatment process.
Okay. Very, very, very important thing. And I think that's what we're really trying to drive home is high alert and refer once you have significant concern. But sometimes echoes are a little bit tricky. And I'm going to ask Breanne this question. What do you rely most on an echo? Sid talked about high risk features on echo, but what if the symptoms are discordant with the echo? Or what if you're not seeing an elevated pulmonary pressure? Does it still help you in the evaluation? And what part of the echo do you look at?
So unfortunately, as I've learned, there's not one single measurement on echo that's a slam dunk for pulmonary hypertension. So you really have to look at the entire echo, look at multiple parameters, and really integrate different parameters to decide how likely it is that a patient has PH. So when I'm first looking at an echo, I would start with the RV. I'm first looking at it visually. What's the free wall doing? Is it moving well? Is there any evidence of interventricular septal flattening or even bowing? Is there an RV that is dilated and bigger than the LV? Is that RV actually even apex forming? Then I'm looking more at the quantitative measurements of RV function. So I'm looking at TAPSE, RV fractional area change, RV free wall strain, and the tricuspid annulus velocity are all kind of measures to look at for that. And then I'm also noting if the RV is thickened or has trabeculations, because that can sometimes give you a clue to the chronicity of the disease. And then next, after the RV, I look at some of the pulmonary artery parameters. So of course, looking at elevated PASP, but I think what's really important and what the newer guidelines suggest is to actually start moving away from just the PASP and look at if there's evidence of an increased peak tricuspid regurgitation velocity. And that's because the PASP has some problems with its measurement. It's a calculated value and it's coming from the right atrial pressure, which I think we all know isn't the most reliable measurement on echo. And then I'm also looking, is there mid-systolic notching of the RVOT, dilated right atrium, dilated IVC, and then a pericardial effusion. And those are kind of all of the things that I'm looking at on an echo. And if I'm looking at my echo and my patient, and I think that there's a discordant result and it's not really making sense, I first want to look at, what were the windows like for the echo? What was the quality of the study? I'm looking at all of those multiple parameters to see if there's a normal PASP, but multiple measures of a decreased RV function that may still clue me onto something being abnormal. And honestly, if my suspicion is high enough, none of our tests are ever perfect in medicine, I will just send the patient to get a right heart cath.
Perfect answer. And you would make your mentors very proud because you highlighted how valuable an echo is, and it far exceeds the TR jet velocity. So many things we can learn and so many triggers that an echo can have for further workup. And then I'm going to ask Sid, so now you're going to get the right heart catheterization. What parameters do you look at on the right heart catheterization? And what is the hemodynamic thresholds for the diagnosis of pulmonary hypertension in today's day?
And in today's day, as far as I've known in my training, the magic number is 20. So you check pulmonary artery pressures, and then the mean pulmonary artery pressure greater than 20 gives you your diagnosis of pulmonary hypertension. And then outside of that, to further stratify or to classify these patients, the way that we've been taught is to think about it as pre-capillary pulmonary hypertension versus post-capillary pulmonary hypertension. And for those of you can see the table that's shown here, obviously there's different variations of that because there's isolated post-capillary hypertension, but then there's also combined. So when we're looking at how to classify that outside of the mean PA, additional values that truly help us are the pulmonary artery wedge pressure or the capillary wedge pressure, just to help us determine what the left side of the heart pressures are doing. And that number, as you can see on the table, is 15. And then on top of that, what we look at is the pulmonary vascular resistance, which when I started training, we were taught it was 3 Woods units, which has already changed in my time in training. Now the threshold is 2 Woods units. So typically, if the wedge is low and the PVR is high above those thresholds, that gives us the definition of pre-capillary pulmonary hypertension. And conversely, if the wedge is high and the PVR is low, then we are given the diagnosis or the definition of post-pulmonary capillary pulmonary hypertension. And then we have this gray area, or this complex picture where the wedge remains high, but then the PVR is above 2. That's when we have combined both pre and post-capillary hypertension. I think the big caveat here, a couple of caveats here, is that it's very important to ensure that the patients are as euvolemic as possible, because obviously if the patient is volume overloaded, then that might falsely give you an elevated wedge above what their actual baseline is. And as you can see, based off of the wedge, you are able to define these patients a lot clearer. So ensuring that they're euvolemic and that you have the most accurate wedge is very important. And I think that kind of goes along into the fact that also it's important, or this has been hammered in our heads during training, but to make sure that we are also evaluating the waveforms ourselves during a right heart catheterization, just to ensure that we are able to determine what the wedge is, and just to kind of quality check what the intensivists are also recording, because sometimes they're very busy and they're just marking down a number based off of a reading, but just to ensure that the patients are getting the most accurate diagnosis possible is very important.
Because this is our biopsy, right? If we don't get this part right, we'll send people in the wrong direction. And if they're sent in the wrong direction, then they'll get the wrong treatment. And then a disease that could be modified will actually maybe be harmed by that. So exactly what you said, really getting good numbers in a setting where you can look at all of the data yourself to make the best decision for your patient. So now we got a diagnosis. Now we're going to try to figure out how to manage. So I'm going to ask Breanne, when you get a new patient, you're looking at their risk and you look at multiple parameters. What do you think are the big, most important, the greatest drivers of how you'll manage them? And how do they inform how you're going to treat the patient?
So I think when I first get a patient with a new diagnosis of PH, the overall goal is to really identify those high risk features. And part of that is to be able to group patients into a low, intermediate, or high risk, because then that's going to drive my follow-up planning and, as you mentioned, treatment strategies. So some of the ones that I think are the most important and that also are found in the risk calculators are the pro-BNP level, also getting a 6-minute walk distance on the patient, which is also important to follow over time. If you have the right heart cath tracings, check to make sure that those are good, as Sid mentioned, and then look at the right heart cath. On that baseline cath, I'm looking for things like, is the cardiac index reduced? Looking for an elevated right atrial pressure or low mixed venous O2 sat. And of course, I'm also noting the pulmonary capillary wedge pressure and PVR, but really those earlier metrics, the index, the right atrial pressure, and the mixed venous sat are pretty important for noting if your patient has a high risk feature. On the echo, I'm more concerned about a patient if they have a dilated right atrium, if they have a pericardial effusion, or if they have reduced RV function. And then clinically, I'm considering what's this patient's functional status, and do they already have markers of volume overload on exam? And I think another thing that part of the initial workup should also include is really just seeing what is the pace of disease, what's their disease trajectory, and is this someone who is progressing rapidly and who you really need to prioritize expediting their workup, getting them on treatment early, and maybe even considering early transplant referral.
Very, very good. You know what that drove home to me is that this is not simple. You really have to have a global approach. And sometimes one part may be different than another. You might have advanced symptoms and less advanced hemodynamics or vice versa. And you have to figure out how that actually fits into that patient and what to do next. So I'm going to ask Sid, getting all that information and putting it in a risk assessment tool, how does that help you? How does the low risk patient approach differ from the high risk patient approach?
Yeah, definitely. So I feel like a table that's kind of ingrained into our memory, working with these patients, the three-strata model. And basically, everything that Breanne mentioned, it kind of puts it into a low risk, intermediate risk, and high risk category. And based on the severity of those markers and the symptoms and the findings on right heart cath, we're able to put these patients into these three buckets, and that helps determine how aggressive we need to be up front versus if we have some time to maybe start with initially monotherapy or maybe just 2 oral therapies up front. And the whole point of kind of putting them into these categories based on the way I think about it is, if a patient has the majority of their symptoms under one column, that's usually what I classify the patient as having, whether it be low, intermediate, or high. And so, yeah, based off of their severity, there is a 1-year mortality estimate that's associated with each one. So low risk is associated with a 5% 1-year mortality, whereas a high risk is a greater than 20% risk of 1-year mortality. So I think getting all the data and putting it in a schema that is tried and true, like the three-strata model is very useful in helping us determine who we need to be more aggressive with.
No, very, very good. It gives you a framework, and not every patient's going to fit everything. However, we have to have somewhere to start and understand the risk of our patients. Now, when we follow patients, so we get this at an initial assessment, and then we start our therapies based on the severity of illness, and it might be infusion therapy on our sickest patients, or it could be that dual combination up front, as Sid mentioned, with our low or intermediate risk patients, but then we see them back and we reevaluate. Breanne, how do you use these risk tools going forward, and how do they influence long-term planning?
So mentioned, so at every follow-up appointment, it's important to continue assessing risk and seeing how the treatments that you've implemented are hopefully changing things. So at every visit, I'll look at a risk calculator. I personally like European for three-strata or Reveal Light 2, but any of the validated risk tools are able to be used. There are also online calculators that I really like for these that make it possible to calculate a score in the setting of a quick clinic visit. As for how these really impact my long-term care planning, I think it helps both me and my patients really understand disease trajectory and adjust management appropriately. So adjusting follow-up frequency. So if my patients are intermediate or high risk, seeing them at least every 3 months, sometimes more frequently, while patients who are low risk and who are maintaining that low risk status on treatment may be able to be spaced out to every 6 months or so. Risk status can also trigger, as I mentioned before, referral for transplant if my patients are still intermediate or high risk despite being on treatment. In addition to escalating therapy, that's also an indication for referral. And then particularly if I'm ever practicing outside of a PH center in the future, I think that monitoring risk scores over time also be really critical for determining what patients need to be referred to a PH center. It's encouraged for all patients who are intermediate, but especially high risk, to be referred. But I think that looking at someone's risk score and seeing how that changes over time can really help you to identify which patients are getting sicker or just not doing well in the treatments that you already have to offer, and predict who may get worse and need more advanced therapies, need transplant capabilities, and really prioritize getting those patients to a center, especially if it's not easily accessible.
No, very, very key point here, that people need to be progressing in the right direction, or we need to reassess and even think about transplant in our patients that are not progressing the way we would like them to be improving. So now we talked about getting the diagnosis, evaluating the patient, doing risk assessment. But when we're talking to the patient, Sid, what are you talking about in terms of goals? Give me 2 or 3 things you talk to them about, what you hope to achieve when you treat them with sometimes very complex medications.
Yeah. Oh, I feel like focusing on goals is an uphill battle in patients with pulmonary arterial hypertension, especially if it's very advanced. So I think something as quote unquote simple as making them feel better, reducing their dyspnea on exertion, seeing if they're able to perform activities of daily living where they weren't doing that a couple of months ago, helping reduce the sense of abdominal fullness or lower extremity edema if that's their primary issue. I think helping them subjectively improve, I think, is just as important as fixing numbers, either with a right heart cath or numerically what you see on an echocardiogram. So I feel like always focusing on symptoms for patients is an easier way for them to get motivated and stay on board with the sometimes complex treatment plans.
Very true. And really have that shared decision making, knowing what's important to the patient and what's important to you in terms of their goals for treatment, and trying to marry them in some meaningful way, which can be challenging because we're asking very complicated things from patients who may not have any medical background at all. So Breanne, when you talk to patients, what do you expect and what do you advise them that you're hoping to achieve in that first year after diagnosis?
So the key treatment goal, and what I would share with patients, is that we are starting these therapies in order to ideally achieve what we call low risk status within our first 6 to 12 months of starting medications. And this is because we know that patients who start and therapy, if they're able to achieve and then maintain low risk status within that first year, that critical first year, they have significantly improved long-term survival compared to patients patients who don't. So that's why in that first year, we're going to be seeing them frequently. It's every 3 months, reassessing if we aren't hitting those treatment goals, if we're not hitting low risk status, if the patient's not feeling better, having an improved functional class, if the biomarkers are better, the RV function isn't improving on echo, if any of these things are happening, that's why we then escalate treatment. And it's really because we know that treatment matters for patients' outcomes.
Mhm. Definitely. Lower status is always our goal, and for our patients to feel better and be satisfied with their treatment. So, Sid, what's changed since you started your fellowship? You mentioned one thing, the PVR. What else has changed?
Yeah. I feel like two major things that have changed, actually three, I guess. One of them, which I thought was very cool, was the combination therapy. So medications that have come out that have combined both um, a, a nitric oxide pathway inhibitor plus a endothelin receptor antagonist. So I feel like that combination pill has really helped kind of consolidate therapy for patients, which I think is a great thing to ensure that patients remain compliant.
Mhm.
Another medication that we've been seeing a lot of our patients use more and more lately, especially with the combined interstitial lung disease population, is treprostinil. So not only the IV form, but especially the inhaled form, whether it's in a handheld inhaler or a nebulizer, which is just another modality, another way that patients can have the drug administered. And we've seen in studies that showed that they have a lot of benefit. And then the biggest thing has happened in the last year with the approval of sotatercept, and seeing our patients get started on that when they're already on 2 or 3 medications, and seeing significant improvement and less hospitalizations has been very promising. And it's definitely very uplifting in a field where I feel like a lot of the times we're trying to just slow progression and prevent mortality, and facing an uphill battle. So seeing a new medication get approved and see a lot of positive outcomes has been very important.
Yes. So you've been through a lot of changes in a short period
Yeah,
of time. It's very exciting, very
yeah,
exciting. So, and I am so proud of both of you because you have learned so much about pulmonary hypertension. And I hope that in your next steps in your career that you can share that knowledge so we can make an impact on time to diagnosis and time to correct therapies. So I'm going to ask you both one question about your training. Why do you think pulmonary hypertension focused education and mentorship is essential for pulmonary training? And what would you recommend to other fellows to ask for, to look for, and other individuals who want to learn about pulmonary hypertension? What would you recommend they do to learn as much as you guys have in the last 3 years?
Just to
Sid
say,
or
obviously,
Breanne?
oh, sorry.
Great, great.
Everything has changed in the past few years, and there's a lot changing in PH now. I think the field's going to look very different in another 5 to 10 years. So just being able to recognize that, I think having education in pulmonary fellowship is critical to know what symptoms to look for, to know what diagnostic tests to order, and what to do if those diagnostic tests aren't really fitting the clinical picture. And that's something that's important for any pulmonologist, any cardiologist practicing, because we see these patients and often have to start the diagnostic workup, even if you're not a PH specialist. So having some part of pulmonary fellowship focus specifically on PH training is critical, especially because PH is such a rare disease. Not every fellow is going to be able to see enough patients with PAH to understand how to appropriately work up and manage. So having workshops, having asynchronous learning opportunities, having lecture series that every fellow can be part of, I think is really important.
No, that's so important, and I wish we could have more of that across the country. So, as I said, hopefully we'll be able to all share our knowledge going forward. Sid, what do you think?
I definitely think raising awareness for the disorder in general has helped a lot. I feel like even since I was a resident in training, then moving on through fellowship, there's just been more and more knowledge about the disease, and just more people advocating for the education of pulmonary hypertension. So I think that's very important. And I agree with Breanne that if you're not at a place that is a center for pulmonary hypertension, then definitely having asynchronous learning opportunities and seminars are very, very important.
So thank you guys. This was wonderful. I do want to just comment on one question from the audience. It was a question about congenital heart disease and pulmonary hypertension and an ASD. And that is a very tricky question, so I'm going to take it. So when we meet someone who has severe pulmonary hypertension and we find a right to left shunt and it's atrial level, I think we have to still evaluate for every other cause, because it might be just a PFO with shunting because of high right atrial pressures. And just because you have an atrial septal defect, even if you find one, it may not be the entire answer. So people do have poor outcomes with pulmonary hypertension. So the question was about, can that be a cause of their death? And that is true that our patients can be very, very sick when we meet them. But regardless of what you find, you want to look for the entire evaluation to try to assess and then treat them as aggressively as you can, and contact your local or regional or national pulmonary hypertension program to help you with their care. So I want to say thank you all for being with me today. Sid, Breanne, this was wonderful. Today's session really highlighted the importance of pulmonary hypertension care and how it really impacts recognition. So we talked about the tools we have, how to diagnose patients, and hopefully that will help others to better detect and refer patients so they can have the same opportunities many of our patients do. So have a wonderful afternoon. Thank you all very much for joining us.
Thank you.
Thank you.